All right. Good morning, everyone. My name is Magda Sanz Cortez. I'm one of the fetal surgeons at Texas Children's Hospital. And today it is my pleasure to co-host today's webinar on Spina Bifida. We're going to have some fascinating talks that will cover the diagnosis and management of those babies diagnosed and repaired after the diagnosis of Spina Bifida. We're going to have some speakers that will cover different aspects of this field. We're going to hear about the imaging aspect, the ultrasound and MRI. We're going to hear also about the in utero repair and how these babies should be followed up after they're born. And finally, we'll be hearing about some cutting edge advances and innovation on research and stem cell. I'm going to introduce my co-host, Dr. Alarisa Shamshirsaz, and so he can introduce the first speaker.
Welcome, everybody. This should be a very interesting webinar. We have a multidisciplinary approach, and I'm honored to introduce our first speaker. She's Dr. Amy Mulholland-Ray. She's Associate Professor of Radiology and Obstetrics and Gynecology of Baylor College of Medicine. She's also the chief of the fetal radiology division at Texas Children's Hospital. I'm working with Amy for about 10 years, and she's an incredible radiologist. Amy?
Thank you so much for that introduction. I'm going to go ahead and share my screen and start my PowerPoint. And I apologize, I have a lot of screens, so that always takes me an extra minute. Okay, so I'm going to talk to you all about how we do fetal imaging for neural tube defects, really with a focus on identifying candidates for prenatal surgery. I have no disclosures. My objectives for the next 15 or 20 minutes are to really kind of explore the prenatal imaging aspect and how we diagnose neural tube defects, with a focus on understanding the fetal surgical criteria and identifying patients that will be good surgical candidates. And we'll also talk a little bit about the expected and unexpected postoperative appearance prenatally. So as a fetal imager, I often find myself in the position of needing to determine which fetus would make a good prenatal surgical candidate and which ones would not. So when evaluating a new fetal referral for neural tube defect, we have to answer these questions. So first, is the defect open or closed? Meaning, is there a CSF leak or is the defect covered by skin? If skin covered or closed, they are not a candidate for fetal surgery. Next, we need to know, is there hindbrain herniation, which is considered a requirement based on the MOMS trial? What is the upper level of the lesion? Do we already see ventriculomegaly? What is the motor function? And lastly, is there any other finding that would exclude this fetus as a fetal surgery candidate? So starting with the first question, is the defect open or closed? We see on these two ultrasound images a flat defect, which you can call a myelocele or myeloschisis. Flat defects are straightforward, they must be open. So those are easy. Here's the same patient at fetal MRI. These are axial and sagittal single-shot T2 weighted sequences where you can see there is this flat defect in the lumbar region. There's no sac of fluid overlying it. The neural placode here at the arrow is tethered at the defect level, but does not protrude beyond the plane of the lower back. And as you may already be aware, sometimes it's really hard on MRI to see one fluid-filled structure like a myelomeningocele sac within another fluid-filled space, in this case, the amniotic fluid, due to how thin the sac wall is and other artifacts like amniotic fluid motion. So this is my tip. If you're not sure about a sac and you don't have access to ultrasound, pay attention to the position of that tethered neural placode. So if there's no sac, and this is a myeloschisis, the neural placode will be tethered at the level of the lower back. So a lesion with a sac could be open or closed. If you see the typical lemon head shape of the calvarium and the banana sign of the cerebellum, there's a good chance you're dealing with a CSF leak through an open defect. This is the same fetus on MRI, and this fetus was moving a lot, requiring us to rely more heavily on balanced, steady state free precession sequences rather than our usual T2 weighted sequences. And you can see that the sac is really subtle here against this bright background of amniotic fluid. So here's where my trick comes in. If you look at this series of axial images going through the defect from cranial to caudal, you can see how the neural placode extends beyond the level of the lower back soft tissues. And that is because this lesion has a sac. How about this case? So there's a large sac here on a transverse ultrasound image of the low spine. But when you look at the brain, the posterior fossa looks normal. And if you look from behind in the sagittal plane at the craniocervical junction, you can see that there's just CSF fluid in that space. There's no hindbrain herniation. Is this one open or closed? So again, this seems straightforward. There is a KRI2 malformation, but now here's where the subtlety comes in. If you look at the margins of this lesion, at the acuity of the angle with the lower back and at the transition from the skin to the sac wall, you'll notice something a little bit different. This was an MRI focus paper, and we can take away that there is a difference between the closed defects and the open ones when you pay close attention to this tissue leading up to the sac. So when there is subcutaneous fat that's extending into the sac wall, it makes this obtuse angle and a thicker margin. And that is a way you can distinguish closed spinal dysraphisms from open ones, because the open lesions will have a more acute angle and thinner margins. You'll notice whenever I have a reference, I've included a QR code. You can use your phone's camera to scan that, and it will link you to the article for your convenience. This is the same patient that we just saw on MRI, and you can see the same finding that we saw on MRI is shown on ultrasound, where we have this obtuse angle between the lower back and the sac, and we have thick tissue extending into the sac wall. So this was a closed defect. This one is more obvious even at the sac margins, but there's also no Chiari malformation, so that helps. But you should be paying very close attention to the sac margins, as this is really a key finding in separating the open from the closed neural tube defects. So we've determined that we have an open defect with the Chiari2, but we know that you can have Chiari2 malformation, but there does not necessarily have to be hindbrain herniation with it. Here are two sagittal images of the craniocervical junction with the patient on the left having a Chiari2 malformation. And you can see that there's hindbrain tissue herniating down behind the spinal cord and filling in the cisterna magna and that retrospinal space. There's a normal patient here on the right shown for comparison. In the MOMS trial, it was written that hindbrain herniation must be documented by MRI. But I think that there are patients in which you can clearly document hindbrain herniation on ultrasound. If you have any concern or lack of certainty, then MRI is preferred. So this series of images is to show that you can grade the degree of Chiari2 malformation, and this is a grading system used by Cincinnati. So the fetus on the far left is a normal fetus. You have fluid in the fourth ventricle and fluid in the cisterna magna. The next fetus would be called grade 1. You have a Chiari2, everything looks really crowded, but you still have a little bit of fluid visible in the fourth ventricle and in the cisterna magna. In grade 2, you have effacement of the fourth ventricle, but maintenance of fluid in the cisterna magna. And then in grade 3, both the fourth ventricle and the cisterna magna are effaced. Patients that have a Chiari2 malformation, but they do not have hindbrain herniation, do not qualify for fetal surgery. The next question to answer is, where does the bony defect begin? We focus on the bony defect and not the skin defect, because the bony defect is typically within one vertebral level of the neurologic level of deficit. To qualify, the spina bifida should begin between the T1 level and the S1 level. We use a 3D ultrasound acquisition, and we correlate between the sagittal plane, the coronal 3D, which helps to show the last rib and the sacrum, and then the axial to show the site where the posterior elements begin to open. So starting with this image, we've labeled this one T12. We have the 12th rib in the picture, and then we move down the spine. So this is L1, and we see that the posterior elements are still closed. They form that little housetop shape. L2 still intact, L3 still intact, L4 still intact, and then we reach the L5 level and the posterior elements are open. So we've identified the bony level at being at L5, and sometimes the skin level is below this. So that's why it's so important to pay close attention to the posterior elements and to count correctly. And then this is the S1 level showing that that is still open. Identifying ventriculomegaly is pretty straightforward on ultrasound. So this is Laurent Guibaud's article, which provides good reference images on how to do this consistently. So you should have on a transverse image, symmetric cerebral hemispheres. You should be able to see the columns of the fornices anteriorly, and they have that characteristic kind of 2 hypoechoic bands with 3 hyperechoic interfaces. And then the ambient cistern here should have a nice V shape. When you can get an image like this, you take the lateral ventricle measurement at the deepest portion of this internal parietal occipital sulcus, as shown on these images from the article. We measure at the same landmark on MRI as shown here, but in general, the measurement by MRI is about 1 millimeter greater than what we obtain on ultrasound, even when you take the images back to back. Why do we care so much about lateral ventricular size preoperatively? So this is from a paper from the MOMS group looking at breaking down the patients that had prenatal surgery compared to postnatal surgery and whether they needed treatment for hydrocephalus in infancy. And it would make sense that the larger your lateral ventricular size, the more likely you would need shunt placement or other hydrocephalus treatment postnatally. But it's interesting to note that even in the fetal surgery patients with prenatal repair, when you got to ventriculomegaly in the severe range, so greater than 15 millimeters, those rates are approaching pretty similar numbers to the postnatal repair group. So it's important to look at the size of the ventricles prenatally because you should be able to predict whether or not you think those fetuses will go on postnatally to need treatment for hydrocephalus. I also pay special attention to the preoperative lateral ventricles when they are asymmetrically dilated. So here's a recent case that we saw referred at 22 weeks where the left lateral ventricle was bigger than the right, as you can see here. The left was actually about 20 millimeters when the right was 12 millimeters. And you'll notice where I've got the arrows that the cortex that was sort of medial to the left occipital horn was so thin as to basically be imperceptible, whereas we can still see a little bit of occipital cortex on the right. On MRI, we see the same finding, and we call this a lateral ventricular diverticulum, where basically the cortex here has become so thin that the ventricle sort of pooches out. And on the coronal, you can see what this is doing to your posterior fossa. It's also pushing down on the posterior fossa and further complicating the crowding of the posterior fossa. So when you see this, when you see asymmetric lateral ventriculomegaly and you notice this formation of a lateral ventricular diverticulum, you should be thinking about aqueductal stenosis occurring on top of the Chiari-2 malformation. So that's really important because even with repair, there is something that we're not able to treat with repair here, which is the aqueductal stenosis. So we would anticipate that this ventriculomegaly would continue to progress. On ultrasound, when we are looking at the question of motor defect, we look for clubbing of the feet and ankles and fixed flexion or extension at the knees and hips. So on this ultrasound image here, you can see that both feet are clubbed and those were fixed with no ankle or foot movement on ultrasound. You can also assess this with dynamic imaging on MRI, and this is really a key technique for fetal imaging of neural tube defects. We've taken a thick slab dynamic. We use our usual balanced steady state free precession sequence, but we increase the slice thickness, from what was maybe 3 millimeters in a normal sequence to about 20 millimeters. And then instead of running a series of sequences kind of over space, we just hold it in place and we run it over time. And that gives you this sequence that shows fetal motion. You may have to run it a couple times in order to capture foot and ankle motion. You can use this table as a standard to follow, where if we see ankle plantar flexion, which we refer to as gas pedal movement, then we know that motor function is intact all the way down to S1. If you don't see ankle plantar flexion, you can back up to the highest intact level that you do see, and that would help, that would determine your motor level. For this patient, we had intact motor function, and you can imagine the fetus sort of stomping on the gas. I recommend if you're going to view this article that you do so on the publisher's website because there are some nice videos showing examples of different levels of intact motor function. Not all motor function manifests as clubbing, as shown on the fetus on the left. Sometimes we will see a rocker bottom configuration as a sequela of denervation, so that's important to pay attention to. Lastly, we need to assess the fetus and the uterus for potential exclusion factors for fetal surgery that we can identify on imaging. So there are other exclusion factors, which I'm not listing here, like history of prior preterm delivery, because those are clinical. So I'm really talking specifically about imaging exclusions. There are 4 maternal and placental features that can be assessed on imaging and 2 fetal features. And I'm going to skip over cervical shortening, abnormal cord insertion, and placenta previa, as those are self-explanatory. Uterine anomalies, though, are tricky. Sometimes the mother may already be aware of a uterine anomaly from prior pregnancies, but if not, we need to be paying very close attention on ultrasound and MRI. So here's a mom that on MRI has an empty horn off to the right. And this was so subtle on ultrasound. In fact, we didn't see it prospectively on ultrasound. We could only see it retrospectively. And on this clip, it's at the start of the clip. So we're going to go back through. This was just sort of a uterine clip, kind of looking at fetal lie. So we weren't even really focused on the uterus for malformation. But if I go back to the beginning here, there's that empty horn off to the right. So the reason uterine anomalies are considered an exclusion is because of the risk of preterm delivery. And this is really an area where MRI has a huge advantage over ultrasound because these are much more straightforward on MRI. Regarding fetal exclusion factors, significant kyphosis can complicate fetal defect closure and is considered a relative contraindication. So this case was a long lesion. It started at T9 and ended at L5, and it was associated with this upper lumbar kyphosis as shown in the ultrasound clip that measured about 32 degrees. On the MR images from the same fetus, you can see how challenging it would be to cover this completely at the time of fetal surgery. Other fetal anomalies are important to look for. So this was a fetus that had a neural tube defect, but also had caudal dysgenesis. So on this clip, you can see that the sacrum seems to end kind of abruptly. And this happened to be a mother that had poorly controlled diabetes mellitus, as you can see also here from all the thickened subcutaneous tissue and cardiomegaly. We do need to be careful about what we call an unrelated anomaly. So callosal dysgenesis, as shown in the fetus on the left, and subependymal heterotopia, as seen on the right, are part of the Chiari-2 malformation. So they're not considered unrelated or significant malformations that would exclude a patient from being considered for fetal surgery. Just a brief word about follow-up fetal imaging after prenatal repair. We do expect to see hindbrain herniation reversal with ascent of the hindbrain structures and return of fluid to the fourth ventricle and the cisterna magna. And we do generally see an increase in the CSF spaces everywhere. That also includes a mild increase in lateral ventricle size on the order of just a few millimeters. When there is still a leak, however, the hindbrain herniation and effacement of the CSF spaces will persist on follow-up, as you can see here, comparing the initial imaging on the left with the postoperative imaging on the right. When the fetus doesn't show the expected reversal of hindbrain herniation, there's high risk that they're going to need treatment for hydrocephalus postnatally. It's also important, if you don't see the expected change in the posterior fossa, to take a careful look at the repair site, as in this case where we see a collection at the repair site, which we call a pseudomeningocele, and this can be evidence of ongoing CSF leak at the repair site. And very lastly, it's important to pay attention to the uterus post-repair, particularly for any signs of uterine dehiscence as shown here. And this is another area where MRI has an advantage over ultrasound. So to summarize, when evaluating a potential candidate for fetal NTD repair, we need to identify whether the defect is open or closed, show that there is hindbrain herniation, identify the highest level of the bony defect, look for pre-existing ventriculomegaly, assess for any motor deficit, and ensure that there are no maternal or fetal exclusion criteria. Thank you so much for your time. Please consider scanning this QR code with your phone's camera to give me feedback on this talk. And here's my email address if you have any questions. Thank you.
Thank you so much, Amy. That was an excellent presentation, and I think that it was very practical. I'm sure that people are going to have comments and questions. I'm going to invite everyone to use the Q&A box that you can see on your screen. So you can start typing those questions so that when it's time to ask Dr. Mahalan-Ray, we know where the audience's interests are. And now we're going to introduce our next speaker, Dr. Bill Whitehead. He is a professor of neurosurgery at Baylor College of Medicine and has been a pediatric neurosurgeon working at Texas Children's Hospital for over 15 years. He is a founding member of the Hydrocephalus Clinical Research Network, and his research interests are based on Spina Bifida and also on hydrocephalus. And today he's going to be talking about the in utero repair of Spina Bifida. Thank you, Bill. Welcome.
Thanks, Magda. Can you see my slides okay?
We can see your camera. We don't see your slides yet.
That should be
okay.
better.
Now you're sharing your screen. We can see your screen now.
Great. Well, thank you for that introduction. So this talk is about a neurosurgeon's perspective, specifically mine. So there will be data in this talk, but most of this is going to be my perspective on the place that in utero repair has in the care of these patients with myelomeningocele. And I'll just start off with two observations that really helped shape this presentation. And the first is that the best outcomes that I've seen in patients with myelomeningocele have been after fetal repair. And then the second observation is that the worst outcomes that I've seen in myelomeningocele patients have also been in patients who've had fetal repair. And it's important to remember that and be prepared for the second outcome when things get worse after fetal repair. And you have to be prepared as a team that takes care of these patients, including the pediatricians and the neonatologist, but you also have to prepare the family for that. So I don't have any disclosures. Let me just skip my slides to advance. And I'll make a few points that are really based on those two observations. And one is that a multi-layered closure is key. And we've seen this in our experience, and so have other centers. And I think the best paper that shows this is out of the Children's Hospital of Philadelphia, where they talk about using myofascial flaps to do a multi-layered closure. And this paper came out in 2020. It includes patients that were treated after the MOMS trial. And to summarize their results, their rate of CSF leak went down to 0. And this is in 45 patients. They had a very low rate of, or 0 cases of wound dehiscence. Their hindbrain herniation reversal rate went up to 96%, which was an improvement from the MOMS trial. And then the rate for treatment of hydrocephalus went down to 31%. And a multi-layered closure is what we do in a postnatal repair. And it helps to mimic that in a prenatal repair. You have to make some modifications because fetal tissue can be very fragile. So just to go through that repair, this is a cartoon showing a cross-sectional image through a cystic myelomeningocele. So you see the placoat here, you see the dorsal nerve roots here, the ventral nerve roots here. These are always tethered to the skin, usually by an arachnoid membrane here. And so the first step of the repair, whether you're doing postnatal or prenatal, is to untether the placoat. So you make cuts in this arachnoid to release the placoat from the skin. That allows it to drop into the spinal canal. And then these myofascial flaps are made by making cuts through the dura and the fascia and even the muscle, which makes the flaps more robust. And you can sew them together. If you just use dura like we do in a postnatal repair, frequently the dura will tear and you won't get a watertight closure. We lay a collagen patch, a bovine collagen patch, over the placode to protect it, and then we'll stitch together the myofascial flaps and then the skin. And if we don't have enough skin to close over the defect, we'll make these relaxing incisions that Tulipan described several years ago. It allows us to pull these flaps over the midline, get a watertight seal, and then we let the relaxing incisions heal by secondary intention. We've had to do this in about 20 to 30% of cases. Now, this is what it looks like when you do it fetoscopically. Inferior is at 6 o'clock and superior is at 12. And this is just cauterizing that membrane to release the placode. This is the placodes on the left. You can see it's coming up the right side in this case. And then once the placode's released, we'll make these dural myofascial flaps. And this is cautery, cutting through the dura, also through the fascia and into the muscle to get this layer. And we usually do each quadrant and then mobilize them medially, and then this is the patch being laid over the placode, mostly to protect it during the repair and to hold it in the spinal canal. And this is a commonly used dural substitute that we use in neurosurgery. And then these are 3/0 micrals showing the closure. And typically we place 4 to 5 sutures in the myofascial flaps. And we tie the knots outside the uterus and then slide them. This is a modified Meltzer knot with a bicral stitch. And the thing that we like about this technique is it only puts tension on the tissue at the very end. So by doing it this way, we've had lower incidence of tears and pull-throughs. And then the last layer is the skin. And this is a absorbable monofilament suture, 3/0. In this case, we did a mattress stitch, but frequently now we'll just do a simple stitch in the skin. And we usually place about 6 to 8 sutures in the skin to bring it together. And that's completing the mattress, and then this is sliding that knot. And I think it's important to place the stitches about 3 to 4 millimeters from the skin edge. As you get closer to that skin edge, it's more fragile and there's a higher rate of pull through. So that's what it looks like at the end. Typically when we do it fetoscopically, the repair takes about 2 hours for the neurosurgical part, and somewhere between 30 and 45 minutes when we do open hysterotomy. And if all goes well, that's what it looks like when the baby's born. And since we've adopted this multi-layered closure technique, we've also seen a significant drop in our rate of CSF leak, an increase in our rate of hindbrain herniation reversal, and our rate for treatment of hydrocephalus is about 35%. So I think doing multi-layered closure, if you can do it, if you have the tissue to do it based on the lesion, it's going to lead to better outcomes. But fetal surgery can make the outcome worse, as I alluded to in the beginning, and this is one of our poor outcomes, premature delivery after fetal repair in the NICU, requiring a lot of support. And I'll just go through a few of these poor outcomes just to highlight that bad outcomes can occur with fetal surgery. We usually do the surgery 24 or 25 weeks. In this case, the delivery occurred at 26 weeks. The surgery went well, but for some reason, there was a precipitous delivery on post-op day 3. That baby went on to develop respiratory distress, bronchopulmonary dysplasia, retinopathy of prematurity. Required a G-tube and a tracheostomy. The repair fell apart several weeks after the delivery and had to be redone. That child went on to get hydrocephalus, is non-ambulatory, and was in the hospital for 253 days. Another example, a case that we did at 25 weeks. During the surgery, there was significant bradycardia, and we had to deliver that baby. That child went on to get respiratory distress, bronchopulmonary dysplasia, necrotizing enterocolitis, which was surgical, and retinopathy of prematurity. That child also developed hydrocephalus and is non-ambulatory and was in the hospital for 141 days. We've had deaths in our series. This is one of them. We've had 3 fetal deaths in our whole experience for a mortality rate of about 3%, a little less than 3%. This was a fetoscopic case that we did at 24 weeks. Membrane separation occurred at 27. That patient was admitted to the hospital, had an assessment that was good. Baby was doing well, but the following day, the baby passed away. The autopsy revealed a possible cord accident with 2 loops of cord around the ankle, but we're sure that the membrane separation did not help the situation. So bad outcomes will occur in this endeavor. So you've got to be very careful about patient selection. And we follow the mom's trial criteria pretty closely. There are things that we've relaxed a little bit, things like the BMI for the mother. We now accept less than 40. If we find genetic abnormalities that aren't associated with any known syndrome and the child otherwise meets criteria, sometimes we'll do those cases. But sticking to these helps choose the best patients. And that leads me to this last section about prenatal counseling. And I would emphasize that even if a patient meets the criteria, it's not always the best choice because of the risk involved. At Texas Children's, each of these specialists will meet with the families individually. And then there's usually a team meeting at the end if they choose fetal surgery. And the preoperative workup involves, as Amy alluded to, ultrasound, MRI scan, fetal echo, and genetic testing. Some of the things that I like to talk to families about as they're considering a prenatal and a postnatal repair are family resources. I think to do the procedure, families need to be ready to move to the fetal center. And certainly if there's complications, remain there for 3 months or more. Of course, there has to be a support person to care for the mom. Frequently, the mom has to give up work. If there's other children involved, someone needs to be responsible for caring for them. And if those resources aren't in place, I think that should tip the scale towards a postnatal closure. Similarly, maternal health obviously plays a role. And if there's any health problems on the maternal side, that should also tip the scales towards a postnatal repair. Fetal factors are important too, and the inclusion and exclusion criteria talk about things like hindbrain herniation and severe spinal kyphosis. But the other 2 things that we look at are movement in the legs and the size of the ventricles, like Amy discussed. And so if during the prenatal assessment, there's no movement in the lower extremities with bilateral clubbing of the feet, or it's important to emphasize that fetal surgery is not going to bring that back. So when I see a patient like that, I counsel them that they should not choose fetal surgery for the motor benefit because the legs are already weak and the prognosis for walking is already poor. So the best patients who have the most potential for benefit will have a high lesion where several of the nerve roots are exposed, and good movement at the hip and the knee and the ankle. They have the most to benefit for that outcome. And then Amy showed this slide as well about the ventricular size. And so if the ventricles are big at the time of the assessment, the risk of hydrocephalus is close to 80%, which is the same as a postnatal repair. So in the prenatal counseling, if the ventricles are big, I'll counsel patients that they shouldn't choose fetal surgery for the hydrocephalus benefit, because the risk is approximately the same as a postnatal repair. And the best candidates in this instance have small ventricles, or less than 10, with a rate of hydrocephalus of only 20%. And then the last thing I think should be considered is access to care. When patients live more than 200 miles away from a children's hospital and a pediatric neurosurgeon, that should tip the scales toward fetal repair, because when you have hydrocephalus in a shunt and it fails, you've got to get access to a pediatric neurosurgeon relatively quickly. And the other factor is, especially when you're young, is any illness that leads to irritability and vomiting in a patient with a shunt, or a patient who has hydrocephalus, almost always they're going to be referred back to the children's hospital to make sure the shunt is working. So if you have poor access to care for whatever reason, that should tip the scales, I think, towards a fetal repair. Just some final points. I hear this a lot at fetal meetings, that in utero repair is the new standard of care for myelomeningocele. And when you state it that way, it makes it sound like a postnatal repair is subpar. But I wouldn't put it that way. I think fetal surgery is a good treatment option for very carefully selected patients. And both options are good. And the goal is to help the family make an informed decision. It's important to emphasize during counseling that the safest treatment option for both the baby and the mother is a postnatal repair. And that fetal surgery is not a cure for spina bifida, unfortunately. Of all the comorbidities that we see in this patient population, the two that we know fetal surgery affects, it affects, it's not perfect. I mean, you still can have problems after fetal surgery, and you can still develop hydrocephalus. But the ones that it affects are hydrocephalus and lower extremity weakness. And these other comorbidities, like neurogenic bowel and bladder and tethered cord, we still see in these patients. So I'll stop there and look forward to questions.
Thank you so much, Bill, for an excellent presentation as well. We now have some time for Q&A. So I can see that there's some questions. And I'm going to ask the audience that if you have any comments or questions for both Dr. Whitehead and Dr. Mahalan-Ray, please feel free to type your comments in the Q&A box. I'm going to ask about one of the first questions that we're seeing here. They're asking, and I think that this question would be answered by both of you. They're asking if aqueductal stenosis, if it's part of the spina bifida abnormality, and how do we handle that from the imaging standpoint and also from the eligibility for surgery?
I'll start. I think that's a great question, and I was hoping and happy to see that Bill addressed this a little bit in his presentation also. So I don't necessarily think aqueductal stenosis is part of the QRA2 malformation, although I think that we can have compression of the aqueduct as part of the QRA2 malformation. But I think that we've also seen fetuses that have had pretty significant aqueductal stenosis in addition to the QRA2 that's a little bit out of sort of the range of what we expect. But as Bill said, we sort of look at, well, does that fetus also have clubbed feet and poor lower extremity function? Because if we're not going to help the, hydrocephalus, and we also aren't going to have a benefit in motor function, then that's how we address those sort of on a case-by-case basis.
I would add, that We see it in our spina bifida population or our myelomeningocele cases. We see aqueductal stenosis in about 10% of those patients. And any sort of occlusion of the aqueduct is really going to increase your risk for treatment for hydrocephalus. And there's different forms of aqueductal stenosis. Sometimes there's webs. But I think of that as a migrational abnormality. And most of the findings in Chiari-2 are migrational abnormalities. And this is one that obviously affects the midbrain, part of the brainstem. And so we do see it. And as Amy said, stopping the leak from the myelomeningocele repair is not going to change that. So those patients will tend to have big ventricles in utero, and they'll fall into that group, usually that has ventricles greater than 15 millimeters.
Perfect. I think that's very well answered from both sides. There's a couple of questions for Dr. Whitehead. I'm assuming that whoever wrote these questions is also a neurosurgeon. So one of the questions is, are you concerned about the small amount of arachnoid left on the neural placode? And he's also asking is there enough myofascial tissue in the distal sacrum to completely close that layer in the distal sacral end?
So yes, so the issue there is including epidermal cells and getting spinal inclusion cyst. And so the closer you can make that cut to the placode, the better. But as you get closer, you put the nerve roots at risk. And it's more difficult to do that fetoscopically. We do track our rate of spinal inclusion cyst, and we do see them more commonly in the fetal cases than in the postnatal repairs. And I'll usually do imaging at a year of the spine to see if patients have any signs of a spinal inclusion cyst. And when they're there, I'll follow them until they become symptomatic. The second question about the flaps, in the inferior portion, there isn't as much tissue to work with. And we rely on that patch to buttress that area. And so sometimes we're able to get muscle and fascia over the patch completely. Other times we're not. And then we rely on the patch and then the skin over that for the repair.
Thank you, Bill. We also have connected Dr. Belford. Dr. Belford is the chairman of the Department of OB/GYN here at Baylor. He has been pioneering the fetoscopic spina bifida repair technique together with Dr. Whitehead. And he has, I guess, a question for you, Bill. So Dr. Belford wants to ask you a question.
Morning. Bill, great presentation, Amy, as well. This is kind of a devil's advocate question because I was interested in and have been interested in your approach to fetal surgery all along, and I appreciate it. Is it time now to start considering spina bifida repair in children that don't have an obvious brain herniation if they still have good motor function, simply to offer that to the parents? We all know that there are risks to fetal surgery, but when you look at the real world risk, it's pretty small. And I know that we have to highlight that and we have to always inform patients about the risks, but are we at a point now where saving motor function is in and of itself a goal?
So you cut out a little bit, so I'm just going to make sure I have the question right. Should we be doing fetal repairs on patients who don't have hindbrain herniation?
Yeah.
And, the reason for hindbrain herniation is the leak. And so if you don't have hindbrain herniation, there probably is not that much fluid moving out of the defect, either because it's closed or just the defect is not very permeable. So without hindbrain herniation, your risk of hydrocephalus is lower. And we've followed those patients here that we do postnatal repairs on, and they have a very low rate of hydrocephalus. The motor function, also, I'm not seeing declines in their movement between the prenatal assessment on ultrasound and what we're seeing after the child's born. So the risk of losing function over the course of the pregnancy is also less when you don't see hindbrain herniation. I think that has to do with there's not as much permeability or inflammation or toxicity to the nerve roots. I know the placode is exposed and there's potential for a decline, but most of those kids don't have a motor decline. And so I still think it makes sense not to do it because of the risk.
Do we actually have real data addressing this rate of motor decline with and without hindbrain herniation? Because I've not read that or seen that formally studied. Is that just an impression that you have, or is it actually backed up with that?
You're right. We should look at the data. That's my impression, but it's not just. But I've been thinking we've talked about this before. I look at that, and I'm not seeing it, but I do think it's time to put that series of patients together.
I think that on this note, Dr. Hiroshi wants to make a comment.
Thanks. Hi, everyone. Mike, that's a great question. And I think it's really relevant as we get further from the MOMS trial and as we sort of look at different criteria for surgery. I would posit that your question actually is a corollary to whether or not it's appropriate to offer fetal surgery to a patient that has big ventricles but preserved leg function. Because really, you're not operating for an improvement in shunt rate at all. It's just the other end of the spectrum. That kid's going to get a shunt most likely. So is it appropriate to offer surgery to preserve the motor function? And I think that most of us honestly counsel patients now that the shunt rate and motor function are separate counselable events, so to speak. So I've had the same conversation with people about that exact same question, because if you can offer it for motor function, if the shunt's going to be there, why wouldn't you offer it for a kid to save the motor function if the shunt's not going to be there?
You hit the nail right on the head and said it so eloquently, coming it from the other side. We're already doing it to a large extent. We're counseling people. Your baby has huge ventricles. We're unlikely to help that. So why wouldn't we offer it, saying to the patient, your baby's very unlikely to get a shunt. We're doing this just for the motor function.
Yeah,
I think
but if these behave more like closed neural tube defects, which is what I think based on my experience, then it doesn't make sense to do it.
And that's what I was going to say. I think your point is that the ones that don't herniate have perhaps a different anatomy at the level of the nerves, which preserves them. But that's never been studied to my knowledge. And I think it's time that we perhaps get everybody together and look at our retrospective series and see whether we can follow up on these kids and see. It would be a tragedy if we find out that a lot of these children see significant loss of function over time when we're not offering it to them.
Well, this is a fascinating discussion, and I think that talking about the potentially new indications or expanding the indications for in utero repair is an ongoing conversation in many scientific forums. In the interest of time, I'm going to introduce our next speaker, and there's a question in the Q&A chat box, but I think that both Dr. Castillo and Dr. Whitehead should be able to answer that question after he finishes his talk. So for our next speaker, Dr. Castillo, he is one of the developmental pediatricians here at Texas Children's Hospital. He is the director of the Spina Bifida clinic in our hospital, and he is an expert on babies born with spina bifida and which are the adequate methods to assess their developmental milestones and potential deficits. So it's an honor to have you here, Dr. Castillo. I'm going to let you start your presentation. Thank you.
Thank you so much, Magda, and the organizers for this opportunity. It's a pleasure to be with you guys today and to share just a few thoughts about postnatal repair follow-up, obviously in the light of the new innovations in prenatal repair. Obviously, the question that the Q&A that we just had highlights the importance of longitudinal follow-up. And so to that, I turn for a moment. No relevant conflicts. We all are aware that there's proliferation of surgical programs around the globe. So it's important to consider, well, not only those centers who are doing the cutting edge research, but what are the other centers going to do as they launch this journey? Obviously, we have had many publications from around the world, really, as centers emerge. This is an example from Asia, where what is being highlighted here is the importance of having a comprehensive program set up, the program that encompasses a good number of subspecialties from the very beginning, in not trying to do surgery without considering the implications of postnatal follow-up. Our institution is a good example of this, where in reality, truly it takes a village, from radiology to neurosurgery to obviously to the OP department. Everybody has to be on board and be able to work with each other, not only prenatally, but also postnatally, starting in the NICU. So this is an important aspect to consider when considering how to develop and grow a prenatal program. Our institution, this is an example of the services that are keenly related to the program. Not all of them are present on our weekly multidisciplinary clinic, especially in light of the recent developments with COVID that has cost us, I'm sure, as it has for you in your centers, to have to modify our protocol, but yet remain available to families and be able to respond to today's needs. But in short, it allows you to see the number of subspecialties involved in the longitudinal nature of our program. It is here at Texas Children's Baylor. It's hosted by developmental pediatrics. So we're able to be involved with the families from the prenatal days all the way to 18 to 21 years of age. So it's a comprehensive longitudinal follow-up program. In reality, you must have a organized approach to develop a program that will sustain the answers in the care for the families over time. So our institution, obviously, the clinical evaluation by developmental pediatrics and the rest of the team is the key backbone to not only the studies, but also to the care. And we recognize that there's a number of ways to provide longitudinal studies or data for in this cohort. We turn to some of two usual tools or historical tools, such as the KBID or the Kaufman, which was published, was part of the battery published by Moms Too. So, for example, this is a standard method to follow these patients longitudinally. Yet at the same time, we recognize that there's a real world need to be able to provide follow-up for patients in the real world. In fact, in a center that has a very large catchment area, many patients also come from other states and abroad. So we have to be flexible, and to that we turn to other scales and other methods of study that are important in the real world. From the very beginning, we have, along with you, we have been very interested in functions such as bladder function or neurogenic and bowel and bladder care. So we have been looking at this from the very beginning, thinking, what is going to happen to those patients we follow? Obviously, we have been surprised and encouraged to see that there's no worse outcomes. And in fact, there's favorable outcomes in many of the studies we are currently conducting. Yet, over and over again, I think the refrain is that we do need confirmatory studies to every single study that we're doing, yet because it's such early report of outcomes. We can see benefit not only to the system itself, but also to the child as a whole, obviously beginning in the NICU. it has been noted that incidence, for example, of RDS is decreased. There's certainly a clear association following two-port procedures. So it's important for us to be not only studying the pre and post comparison, but also between approaches. There's a key need for new data and ongoing questions to be asked at each center that is proposing to do this. Additionally, just like it was mentioned, earlier, ultrasound is a key tool for not only case selection, but also counseling of these families. I see, just like Dr. Whitehead was mentioning, I see in real practice a increasing use and reliance appropriately of the ultrasonography and imaging prenatally in terms of parents' questions and the concerns that they bring, and also the need for follow-up postnatally. Not only do we see, and has been reported clearly, a benefit to the index case and the index pregnancy in multiple ways, including gestational age, delivery, but also, of course, there has been clear documentation of subsequent pregnancies also benefiting from a precise approach that follows patients over time, which includes also a higher rate of vaginal deliveries for subsequent pregnancies. So this is very important to families, and it's part of the picture as a whole as we approach counseling. I mentioned briefly a few studies locally, but also I wanted to bring your attention to the CDC's research network, where in fact we are members of this network, and we're able to pull data nationally to look at outcomes that pertain to this domain. One recent study points to the fact that there's no significant increase in the frequency of shunt revisions or tether cord release. Of course, this is early study, and subsequent studies will need to verify these findings. Yet it is important to see that there is a pool of interest and a growing concern for this population, not only at specific centers but also nationally, as more and more centers come online. This is just a quick reminder of that it doesn't take a lot of technology to be able to have an effective follow-up program. It certainly, what it does take is some decision and also collaboration and the will to collaborate and to innovate over time. So in our prenatal program, we have heard the details of that at other presentations. I just wanted to focus a little bit on the tools that we use for postnatal follow-up, which include quality improvement. That is to say that we are always trying to find better ways to care for the families, follow them up, not only acquire data, but also provide real solutions for them as they face the day-to-day challenges of caring for a child with spina bifida. One specific issue that is on the horizon, and I don't think it's too early to bring it up, is just to consider that from the initial study by moms, these individuals are aging. Many of them from the initial studies are now teenagers and soon to transition to adult care, if you can believe that. And so this is an emergent need as we think of longitudinal follow-up, is what are we going to do to really facilitate transition to adult care from those who benefited early from prenatal repair. One example I want to point to is that the AAP, the American Academy of Pediatrics, has convened larger centers to be able to provide some of the initial work as a quality improvement project around transition. And so this is an example of our local team in looking at urological outcomes. Neurogenic bladder health is an important aspect of transitional care. So again, if we're going to open a program and study a program, it's important to be thinking longitudinally about what to do and how to care for these families over the long haul. For those of you who are collaborating with your local pediatricians, I just wanted to point out to some specific resources you can highlight for them. The Spina Bifida Association has published in its index in PubMed, obviously, and also available through their website, spinabifida association.org, a set of guidelines that is comprehensive. It includes 26 specific guidelines in different areas, but these are relevant to today's talk. Certainly, prenatal counseling and neuropsychological follow-up and study, which are available in many ways. And also there is an app, there's a version of these guidelines that is family friendly. In other words, even families can access them and understand in layman's terms what is being proposed over time. Again, I just wanted to provide an overview of some of the outcomes that are being studied and the importance of providing a comprehensive, well-coordinated longitudinal follow-up. And since I have no conflict of interest with this, I also wanted to point ahead and let you know that there will be a World Congress coming up, sponsored by the Spina Bifida Association. And it will be a great avenue to continue this conversation around outcomes and certainly who does qualify and who should these therapies be offered to based on the innovative work that you are doing in your medical centers. So just as a reminder, call for abstracts, it's coming up in May. So as we look ahead, obviously there are some questions that remain and will be important, not just now, but over the next couple of years. Certainly, urological outcomes are of key interest given the complications and the comorbidities associated with that postnatally. Certainly, comparison of techniques is among the top priorities, I think, at many centers. Among the pediatric community, I think the mitigation of care fragmentation is a key concern for many of us as multiple centers open up that may or may not have access to a longitudinal follow-up. So those are questions that remain to be asked and answered, along with questions such as what to do with the aging population that obviously has been started years ago. And soon we will hear about emerging technologies, which is another key aspect of future research. With that, just brief comments, and I wanted to welcome questions in a few minutes for anything related to follow up. Here's my email in case there are questions that I can answer after the talk. Thank you so much.
Thank you very much, Jonathan. It was a great presentation as usual. Definitely we'll come back to you for a question at the end of the session. I'm honored today to introduce our next speaker. Next speaker is Dr. Shinjiro Hiroshi. He is a professor and vice chair of Department of Surgery at UC Davis Health. He's also a chief division of pediatric, general, thoracic, and fetal surgery. And he also is a director of pediatric surgery in Shriven Hospital for Children, Northern California. With that said, he will talk about a new innovation in the field of the neurotube defect fetal surgery. And Shiroji, thanks for accepting our invitation. All yours.
Thanks, Shami, and thanks everyone for attending. Again, thank you for inviting me to participate in this. I am sharing my screen right now. I hope you can see my slides. Great. So I'm here to speak about some of our work after the MOMS trial in terms of innovation in spina bifida surgery prenatally. I think everybody knows that spina bifida is a difficult problem, and this is why we're addressing it with prenatal surgery. Our two-hit hypothesis that we all talk about is essentially with fetal surgery trying to ameliorate the secondary intrauterine damage that happens after the initial defect. I think everyone in the audience probably knows that there was a big trial for myelomeningocele, and this is what we predicate our therapy upon. But the bottom line is, and I'd like to re-quote Dr. Whitehead's slide, that fetal surgery is not a cure for spina bifida, and we still have a lot of work to do in terms of improving outcome for these children. With even in the most controlled settings, 60% of the children still have disabling motor function problems. And again, this was published in the New England Journal. So I'd like to give kudos to our colleagues that are advancing the field in terms of fetoscopic surgery and That's an incredible advance in improving maternal morbidity. But one of the things we wanted to focus on was trying to improve the fetal or neonatal morbidity. So we hypothesized in our lab that we could improve distal neurologic function and help the spinal cord by incorporating biologically active stem cells. And in our simple mindset, we weren't sure exactly how this would work, whether it was neuronal tissue replacement or rescue or protection. But we were interested in pursuing this, and we started with our animal models. We did this in conjunction with a huge number of people. And I should have said my disclosures is that I'm a surgeon. I did very little of the basic science of this other than participating in the lab meetings. And I'll show you all the people that actually did the real work. But we collaborated with our colleagues first at UC Berkeley in bioengineering to help us develop materials with which we would deliver stem cells. And of course, our stem cell experts to help develop these stem cells to be able to implant them during fetal surgery. We identified the ability to isolate placental mesenchymal stromal cells, or PMSCs. And these come from the placenta. And as you know, the placenta is really sort of a protected organ and comes from really fetal tissue. So our initial fantasy was that we could use CVS samples, plate out and isolate PMSCs, expand them in culture, put them on the matrix, the extracellular matrix that we were developing, and give an autologous stem cell transplant to the fetus using their own cells. We discovered a bunch of things about these PMSCs that are really interesting. One is that they grow really quickly in vitro, meaning that the time period actually would work between CVS and time of fetal surgery to expand the colony to have enough cells to be able to implant. And in addition, we found that they're developmentally relevant in that, and interestingly, that they're expandable to different cell lines. They weren't completely totipotent stem cells, but they're multipotent. So they could differentiate into many different kinds of cells, including neuron and glial cells. And this was news to us, and actually we published this in multiple different sources. So we first went about this in our sheep model, and those of you in the audience that have participated in this, and I would like to give actually a shout out to Bettina Pack, who's in the audience, who really is one of the people that innovated this model at UCSF. We used a sheep model where it's a surgical model of spina bifida. We created the defect at day 75 of 145 gestation, went back at 100 days and repaired the defect using 4 groups. One group with no repair, one group with just skin, one group with just the extracellular matrix, excuse me, and one group with the matrix plus the stem cells. These are some representative photos of what these defects look like: the before repair, some with stem cells, the extracellular matrix, and the skin closure. This is what a unrepaired defect looks like in this model, and a repaired model at birth. So again, just comparing what they look like at the time of repair. Here on the screen left is actually a human repair, or a human fetus at open fetal surgery. And here's what the sheep looks like. And it's remarkably similar, at least morphologically. We did try different methods of repair. We floated the cells in a hydrogel, and we use onlay patches. We tried actually amniotic patches from the amnion of the fetus itself, and underwent multiple iterations and found actually the single layer of this ECM with the multi-layer closure seemed to have the best results for us. In order to evaluate these lambs, we actually had to create a local motor scale. And there's a well-known one for rats, the BBB scale, Bresnahan, Beatty, and I've forgotten the third author. But thankfully, these authors are still present at UCSF, so we actually engaged their help in developing this scale for sheep. And so we created a scale essentially from 0 to 15 that helps us quantitate the ability of these sheep to move. Our data suggested actually that if we use stem cells, we had improved SLR scores, meaning that the sheep that got stem cells could walk better. And when we first saw this, we were thinking, oh, this is just, an accident, it's a happy accident. And as we went on and did more and more sheep, we found that it was consistent. I think that looking at the data is interesting, but really probably the best way to see this is to look at a video. These are twin lambs, same mother, same timing of operation. The only difference between these two lambs is one got stem cells and one didn't. And the difference is fairly obvious. And time again, repetitively, we found these improvements in the sheep with stem cells. And this really made us excited about being able to potentially use this therapy in other mammals. So again, this is a sheep lamb that just got the matrix, the extracellular matrix only, no stem cells, and you can see the dense paralysis. On histology, I don't want to belabor this point, but really the main differences became that we saw that we didn't really capitulate the normal morphology of this cross-section of the stem cell, but of the spinal cord, but certainly it was improved in this stem cell group. The biggest thing, though, in cross-sectional histology, that we found that really, if you looked at it qualitatively and quantitatively in terms of large neuron density, that the stem cell animals had improved density that approached that of normals much better than the either unrepaired or the ones with just the matrix alone. So again, implying that the stem cells were doing something to improve neuron density, and maybe this is why a sheep had better outcomes. So this was great, and we're excited about this. And again, we wouldn't be able to do this without our veterinary colleagues. And sort of through a happy accident, one of our veterinary colleagues said, "Hey, did you guys know that bulldogs get spina bifida?" And the answer was no, we didn't know that. But there's a population of bulldogs that get spina bifida, and here's one that has spina bifida, and it's in a little wheelchair and has diapers and whatnot, and it's really a skin-covered lesion. So, and they develop paralysis. And so our question was, well, so we're using human stem cells in sheep. And so it's a xenobiotic model. Would it be helpful to look at another species of animal or another species of mammal to see if it's still effective across species? So we did fetal surgery in some of these spina bifida bulldogs. And again, this is postnatal surgery. This is pre-op evaluation. This is how this bulldog, one of 6, I believe we did, walked prenatally or pre-operatively, sorry. And you can see, for those of you that know dogs, he's supposed to be walking on the tips of his toes, and he's walking more on the flats of his feet. He has some rectal prolapse and has incontinence. So we did fetal surgery for them. Sorry, I keep on saying fetal surgery. My apologies. We did postnatal repair for these bulldogs using the stem cells in a patch. And this is an 8-week post-op evaluation in the same puppy. Now, again, he still has a rectal prolapse. He's still having some issues with incontinence, but it's pretty clear even to the casual observer that his gait appears more normal for a dog. And these results were very exciting to us. And we felt that it would be reasonable then using these data to pursue doing this in humans. So our first step was to identify cell lines that were appropriate to be used in people. And we're very lucky to live in California and have access to the California Institute of Regenerative Medicine, which is basically a funding source that was created after George W. Bush put a moratorium on expansion of stem cell research. And so we were able to get our first grant of about $5.5 million to look at developing stem cell lines for potential use in humans. So we're finding, for finding these stem cell lines, we identified 17 donor placentas, we generated cell lines, and we underwent significant testing, meaning we looked at the donor placentas, we tested the moms for all sorts of viral and infectious etiologies. We cultured the cells. We looked for contamination in those cells and ended up with 8 potential cell lines. We then had to do extensive viral testing to make sure that none of these stem cell lines were infected, and we were able to trim it down to 3 cell lines. We then did safety studies in mice and again in sheep. So looking at the mice, we had to implant these cell lines into mice and then keep them alive for 4 weeks and 6 months respectively to look at any potential health problems in these mice over that time period. And one of the things that our hypothesis was to make sure that we didn't develop any teratogenesis or tumor formation. So a week out, these mice were hanging out. They didn't develop any tumors and did pretty well. We then used PCR to probe them for particular retroviruses and couldn't identify any of that in our animals. And we did blood testing as well as histology. And in histology, we didn't see anything that looked like tumor formation other than fibrosis secondary to surgery. After the mouse studies, we had to do sheep studies, doing very similar studies, looking at just, again, the 2 arms of just the extracellular matrix with the stem cells and then looking at normals. So we had to keep these animals alive post birth for 3 months and study them as well and doing MRIs. So we compared our sheep, that had the fetal surgery, didn't find any significant issues in terms of tumorigenesis or teratogenesis. And again, at 3 months of life, similar findings on MRI, as well as blood and histology. We're actually waiting on the PCR for the study still, which has been ongoing because of delays because of COVID. So then, just to make sure that we weren't looking at sort of happy accidents, again, we did another step looking again at another batch of animals, comparing them and seeing if we had the similar efficacy with the stem cell lines that we had in our hand in sheep again. So we looked again now at 10 fetuses, implanting 3 times 10 to the 5th cells per square centimeter on the extracellular matrix, and made sure that we still had the same results and improvement in walking, looking at our sheep locomotor scales grades. We delivered them all at C-section, and we did assessments again at birth, 1 day and 2 days. And our motor function results mirrored those of the previous studies where we had good outcomes and excellent locomotor scales. And again, video is probably the most telling way to see it. And this is one of our treated sheep that had a surgical spina bifida and stem cells. And they really do walk incredibly normally. And on MRI, again, we had improvement in hindbrain herniation with this repair, as well as no tumorigenesis. So now we had this great science. And the question is whether we could figure out how to get these into people. So we went and talked to the FDA, and after much discussion, it turns out that they didn't want to look at this as a device, and it's more under the umbrella of a drug. So we submitted an investigational new drug application with the FDA. These are these incredibly expensive drug studies that the drug companies tend to pay for. And there's no way that we could have paid for this without this generous funding from CIRM. And there was absolutely no way we were going to be able to pay for it as a state institution. But because we're able to secure this funding through both doctors Farmer and Wang, who are pictured here, we were able to embark on this study. So we've opened the CURE trial, which stands for the Cellular Therapy for In Utero Repair of Myelomeningocele, and using basically mom's criteria, we are implanting fetal stem cells into human fetuses and following them up long-term for motor function, intellectual function, their shunt rates, et cetera. And the study is considered sort of a phase 1 or 2A, with really phase 1 being a safety study, again, looking for things like tumorigenesis, teratogenesis, or abnormal tissue coming from stem cells. And then preliminary efficacy, looking at the motor function of these children. Our current study is we're eligible to use 35 patients. In phase 1, we're in the middle of. The first 6 patients, the FDA wants us to do them in series, so we can implant the cells and do the next one once the patient is delivered. We've done 2 patients so far, and we're actively recruiting our third. In phase 2, after the first 6, we're allowed to do them in parallel, so we can do them as they come. Stem cell transfer takes a lot of work, actually, and we have to utilize our GMP facility here on the UC Davis campus. We're very lucky to have those kind of facilities. Before the day of surgery, the stem cell team works for 4 days, and the day of surgery, they start working at about midnight to prepare the cells. These are our people in our GMP facility in their bunny suits. We bring the cells over, and it sounds ridiculous, but we have to cool them to the right temperature. So we use these wine bottle holders that we use out of California. This is us preparing the cells to bring over up to the operating room. We had to buy a special refrigerator, which our operating room didn't want to store in the OR, so we roll it around campus, bringing it back and forth to be able to store the stem cells in the operating room. All this work was done by our science team, and this is actually an older picture. It's actually larger now. There's a tremendous cast of characters, incredibly talented people that have put this work together. In addition, the surgical team and the clinical team is just as important, just as large, and really helps us do this as a team. Our funding and support from our institutions has also been remarkable, and we couldn't do it without them. Finally, I'd like to put a plug in for the IFMSS meeting, and I'd like to urge everyone to consider coming in November of this year to the IFMSS meeting. I'd be happy to talk about that later if you like. Thank you for your attention. I'd be happy to take any questions.
Thank you very much. It was a very great talk. Lots of new stuff. Before the people start a question, I do have 2 questions. My first question is, do you think you can get these cells through the amniocentesis, or definitely you need the CVS?
Well, we were hoping amniocentesis as well. We can get the cells and we can grow them. The question is timing, but we definitely get more cells from the CVS for sure. But we have people, our stem cell scientists, so we've done this with amniocentesis, spun down the cells, found PMSCs, and I think they can plate them out.
And the second question is, again, all this, effort is going to the improving the lower extremity movement. Do you think through that kind of movement, the first question will be, how much do you expect of the improvement in human? And even if you improve it, do you think that improvement also can get to the bladder and bowel function too?
Yeah, those are great questions. And honestly, we don't know. In fact, in the study, we're partnered with Shriners, which we work with closely. It's literally across the street from our hospital. And that's where our Spina Bifida clinic is. We actually have specific funding looking at the bladder and bowel function for these kids longitudinally, because of course that's a huge source of morbidity for them. In the sheep, we were able to show histologically that some of the bladders and rectums look like they're a little bit less thickened in the treatment arm. It's difficult to figure out how to study the sheep. We actually are trying to see if we can do colonic and rectal manometry on these newborn lambs, but we don't have good normals. So we have to create, again, the normal curve and figure out if our repaired sheep are within that curve or not. It's a great question, though. And it's one that we're super interested in figuring out.
Great, thanks.
Dr. Hiroshi, thanks so much for an excellent presentation. I think that you're just showing us what we might all be doing in years from now. So kudos to you and your team being pioneering on this. I was going to ask you, how does your technique using these type of stem cells differentiate from other patches that are currently on clinical trials for fetal spina bifida repair using similar technologies?
So our technique is pretty much the same as our standard open technique. The difference is generally before we would make a bigger effort to close the dura primarily. And so, depending on the size of the defect, the way you cheat on how you dissect out the dura can determine whether your skin has a big defect or the dura has a big defect. And we tend to cheat in our standard repair, open repair, to close the dura. And then if you need a patch, to use it on the skin. Mm-hmm. The difference here is that this patch needs to go right on the placode. So it's really a dural patch. And we sew it to the dura. So we can leave a little bit more tissue to allow the skin to close easier. So we tend not to need a patch on the skin, although we do have within our IRB and our protocol for this, if you do have a large brachyschisis, that we could use a patch for the repair and then a patch for the skin. Mm-hmm. But it hasn't changed our technique very much, other than to add the complexity of bringing this patch to the OR, making sure that we know the orientation where the cells are up, minimize sort of the scraping of the patch across the tissue and sewing it in with as minimal movement as possible.
But for other stem cell patches that are being used in other centers as part of research, do you see your patch being different in anything in specific or more benefits?
Not particularly, other than I think that there's not that many places that have done as much rigorous work and animal work like we have. And I don't think that it's that other people have as many numbers as we have in terms of the sheep. Like we've done, it's insane how many sheep we've done at this point. I've lost track. Mm-hmm.
And last question for you. So I understand that your work is mainly with the intent of prevention of the deterioration in the motor function. But do you think that if you apply that type of patch on a baby that already has limited motor function in the ankles or the toes or even the knees, do you think that it could revert?
Yeah, actually, our goal for this is actually improvement, not just prevention of deterioration. Our fantasy is that actually these kids get better. And so far, at least from our sheep, they behave on a motor level better than their spinal level, significantly. So it's not just saving, hopefully the motor function, because I think that's what we're sort of aiming for with sort of standard fetal surgery. We're hoping that this improves it to the point where they're more normal.
Mm-hmm. Dr. Belfer has a question for you.
Great. That's just fantastic work and so exciting. And the whole story about bulldogs is very, very interesting. Have you thought, and if I understood correctly, you took postnatal bulldogs and showed improved function using stem cells. Am I correct?
Yeah, exactly. So
why have you not got a
that's right. That's right. Well, because we had started writing the damn grant before we did that stuff, and you're right. I mean, because the population is the postnatals, right? That's the bigger, or honestly, spinal cord injury patients. Like that's the population, because all this stuff is nothing compared to those other populations, right? So from a company standpoint, yeah, no, we need to write a U, right, and make it a multi-center. But but this you're right. So once we saw the bulldogs, it really opened our eyes. We're like, look, if we can make it better post injury or postnatal, and that baby, those pups were weeks postnatal, that they'd been out for a long time. So yeah, absolutely. That's really the rub, is broadening this way outside fetal surgery and looking at, nerve and spinal cord injury.
There's a Nobel Prize there for you, my friend. Go for it.
Oh, I'll just be there clapping and waving the flag. It'll be for one of the scientists.
Flexible is the patch. Can you push the patch down in the small port?
Yeah, we could roll it up and stick it down a port. That's the next thing. The problem is that the cells don't like to stick so much. So we looked at this, and I was fooling around within the lab, and they definitely get scraped off a bit. So we need to figure out a better delivery way. I really think that honestly, if we could figure out how to put it in a gel or something that's liquid, it's some like those matrix gels that we can't use in people, but that stuff that's liquid at room temperature, and when it touches body temperature, it solidifies or turns into a goo. That we use that in the mouse models, but that's not FDA approved for people. But if we could use something like that, I think that would really change the game.
Mm-hmm. There's two questions for you, Dr. Hiroshi. Dr. Tang is asking if the stem cells are immortal after bioengineering. So I'm going.
So that's a great question. So you would think that we could find these stem cells, and so we've labeled them with GFP and other things. And I'm not the scientist that did this stuff, but we can label these, green fluorescent protein and other ways to label the cells. We can't find them. So they do their thing and they go away. And that's actually a very exciting thing for the FDA, right? Because they don't want immortal multipotent stem cells running around your spinal cord or have access to your CNS. So that's actually was a big selling point, is that so far we can't identify these cells, with on postmortem examination of the sheep or mice. So we'll see. Maybe they're differentiating and we're losing them, but so far with our labeling techniques, we can't find them.
That's a great point. And also, Dr. Crispin is asking, if you believe that motor function will improve, wouldn't it have the same effect if you'll do it postnatally? Absolutely.
That's Dr. Belfort's question. I think that really if this trial works, it would be, and if we get an FDA approval, and I probably shouldn't say this in an open forum, but the FDA approval for things, at least in the pediatric world, there's very few things we use in our world that are actually approved for the indication that we're using them for, including our laparoscopic instruments. So we'll see. I do think that really from a financial standpoint, and again, I actually left out my disclosure. I'm not a company guy. We don't own any of these patents. The intellectual property is actually owned all by UC Davis.
Mm-hmm.
But I do think that the market for this will likely be spinal cord injury if it works the way we think it does.
Mm-hmm. One last question. Do you think that the stem cells would have any benefit for the prevention of the hydrocephalus? I mean, anything in the brain related, or just exclusively for the motor function?
So my simplistic understanding, and I think that I might defer to Dr. Whitehead because he may understand this better than I. In fact, I can guarantee he understands better than I do. My simplistic understanding of the hindbrain herniation and the hydrocephalus has to do a lot with the mechanical issues of a fluid leak. And again, I'll tell you, I'm a mechanical engineer, so things that are mechanical really resonate with me. So I'm not so sure that it would help with that. If it does, great, we'll take all the credit. But I suspect that it probably won't, and probably the biggest thing to improve that hindbrain herniation still remains doing a good watertight closure.
Good point. There's another question just right now. Could we use stem cells on detethering surgeries in hopes of restoration?
Again, I do think that if this ends up being something that helps postnatal surgery, it may be something that you use, during, nerve reconstruction or, any of these operations. I think that we can imagine many uses for stem cells in the future. And I think that, this kind of study is just the very beginning of what we're going to do in the future. I mean, really what we'd want to be able to do is harvest stem cells, grow diaphragms for kids with CDH, grow stem cells and grow an esophagus and a plate and put that together for a long gap atresia. And this is just my world. I mean, this is not to mention, the Department of Defense being interested in all of our injured, infantry men and women that get injured in war. We have, thousands and thousands of them now that could potentially benefit from stem cell therapy if it works properly.
Mm-hmm.
So I think that the limits are sort of boundaryless if we could make this work.
Definitely. Thank you.
It was a
Thank
great,
you.
everybody. Again, thank you very much for invitation and joining us in a Saturday morning, and some of the people from outside of the country probably there, Saturday night. Again, it was a great discussion, and hopefully see you in future. Thanks, everybody.